if you need anything afterwards, if you have a little time, I'm sure he has a couple minutes to ask some questions about what his presentation is and what he does. All right, Dr. Roden, thank you.
Judge, thank you very much. It's nice to be back down here and to see everybody when I'm not sitting on the stand talking to you and mostly getting cross-examined. By the way, it's a very interesting system you have where you cross-examine by 12 attorneys at the same time. It's a very unique system in the system of medicine. Just to introduce myself, I'm a pediatric orthopedic surgeon. And that sounds like I'm a child orthopedic surgeon, but maybe child of mine only. My training is, we go off to medical school, we do residency in orthopedic surgery. I did 3 different fellowships. I did a trauma fellowship in pediatric orthopedics, which means extra training. I did a pediatric orthopedic fellowship at Shriners Hospital, Los Angeles, and I did an adult reconstructive fellowship at UCLA doing research through the NIH, where actually we had a fracture lab at UCLA, and we had these cute little bunnies that we would cause fractures, and we would investigate their fractures. They were still cute little bunnies. They gave their best for the VA, and we appreciate it every day. But I've been in practice now almost 30 years. I spent about the first 8 or 10 years in the Shriners Hospital system. I was full-time UCLA, and I was assistant chief of Shriners Los Angeles, still on the faculty of UCLA. So I would see, obviously patients on a daily basis, and now I'm in private practice. Got involved really in doing this type of work, this child abuse type work, years and years and years ago, probably 15 years plus, maybe 20 years, first time I actually testified in this courthouse. Mainly as a way to give information. And that's where I see my job. My job is to help you understand the medical jargon, the medical side of these cases that you take on and have to try to figure out on an ongoing basis. I don't know the law. I don't pretend to know the law. I can never do what they have to do here every day. What I can tell you from medicine is that medicine, a lot of it is interpretation of medical facts and medical language and jargon. So today, as I talk about this, I'm going to give you an overview of some of the things that we look at from the orthopedic side of accidental versus non-accidental trauma. And if you have questions, please chime in to do so. Oh, was working. Did it time out?
Try again.
Bingo. So I want to talk a little bit today about I'll start moving around because I realize I'm going to be blocking some people's view here, so please don't excuse the back. Talk about a little bit what we see, the patterns of injury, differentiating, how you can differentiate or think about accidental injury. By the way, the concept of an accident, is really an interesting concept from my perspective. I can tell you how a fracture happened. I can tell you the pathophysiology in terms of the mechanics. I really can't tell you anything about intent. That's not something I'm trained in or even think about. But so when we talk about accidental versus non-accidental, a lot of times we're talking about patterns. I do want to talk to you about the healing process, because one of the questions I get asked all the time is, here's the scenario that the parents say happened, or here's the scenario that the child abuse expert says happened. Does that fit with the facts of what we see in terms of the healing of the fractures? I'm going to talk to you how we will walk you through that kind of concept. What happens if fractures are left untreated? I mean, understand, people have been healing fractures for about 5 million years before they invented orthopedic surgeons. So I understand we're not all that necessary to some degree. But I do want to give you an idea of what happens in the future. Certain types of fractures, deformity, disability, disfigurement, the big D's, what I call it, and hopefully not death. The ultimate big D. So, number one, bone is alive. We don't think of it that way, but interestingly enough, bone has a very vigorous blood supply. There are stem cells that are constantly turning itself over in the bone. And the blood supply comes from both inside the bone and outside the bone. Interestingly enough, bone itself has no nerve cells. Okay? Bones, 0 nerve cells. It's the only organ in the human body that has no nerve cells itself. And yet the soft tissue around the bone has tons of nerve cells. So that's important, especially when the issue is, gee, should the parent have known that this little fracture was there? What should a reasonable parent have seen or a caregiver have seen? Age determines how things heal in this business. It's unbelievable how it heals. The stem cells themselves are incredibly active, and the stem cells, which are pluripotential cells, live in blood vessels. Stem cells are the most active when we're born. They really almost top out at age 10 to 12, and they slowly are present for the rest of our lives. And we're constantly turning ourselves over. So stem cells exist everywhere. And that's actually the future of medicine, is really in this regenerative medicine world anyway. And I want to talk about the stages of healing. Acute, we call acute versus chronic. Simply said, acute mean happened recently, chronic mean happened over time. Happened a while ago. And that allows us to age some of these fractures. An acute fracture may or may not swell depending on whether or not the bone bleeds. Swelling is caused from bleeding. So if a bone breaks, meaning it cracks like you drop a plate on the floor and it shatters, it's going to disrupt the soft tissue. That's where the blood vessels are, and it's going to disrupt the blood vessels in the bone, and it bleeds like crazy and swells. So a femur fracture that breaks in the middle, you'll see pictures, they swell incredibly fast. A little wrist fracture that a toddler falls onto, it may be no bleeding whatsoever. In fact, the only way a lot of times the parents know is the child stops using it. Or if they tweak their leg, they have a little bending fracture of their leg called a toddler fracture, same thing. They just don't want to walk. And that's the most common reason the parents bring them to see us. Is something's changed. He doesn't want to walk. This is a kid that runs all over the place. He's not walking. So that process is very much age dependent. We talk about callus formation. I'm showing you some pictures of that in a second. Callus is the word we use for new bone formation. The way bones heal is that blood vessels grow into the fracture area. The blood vessels bring the stem cells. Those stem cells convert into bone-producing cells, and they start to make bone. Those of you who've done any welding know exactly what I'm talking about. When you weld, you take two light pieces of metal, you hold them against each other, you heat them up, and you squirt new metal in between, and it fuses the crystals of the bone together, of the metal together. That's how welding happens. And in bone heals the exact same way. These bone cells form. We call this unorganized bone callus, C-A-L-L-O-U-S. The first callus that forms is not really calcified at all. It's clear. And callus starts forming immediately. Fractures become sticky immediately. Over time, typically in children, especially, and I'm talking about a child, I'll say it's anywhere from 6 months to 2 years of age, it appears about 5 to 7 days after the fracture. And mature callus, if you take a look at it over time, that fracture line is the last thing to disappear. It can take a number of weeks, like for example, rib fractures. And remodeling may take even years. So, to give you an idea of what we're talking about, this is a transverse femur fracture. Now nowadays what we do is we put these little rods up the middle of the bone to hold it a lot of times in position, as opposed to the big casts we used to use. But this is an early fracture, which means that you see the fracture coming across, and there is no extra white around it. There's no calcified callus. Over time, if you can appreciate, this is about 10 days out, you see this wad of white coming around. When we see that on the x-ray, depending on the age of the child, the metabolic status of the child, you can date when that fracture likely occurred. And that's a question we get asked all the time. When did it happen? And then over time, this is a little later, you'll see now that there's much more white bone there. Now this is a healed fracture, and the fracture line is no longer visible. And that lump of healed new bone, that callus, that mature callus, it can take anywhere from 6 weeks to 6 months to disappear. And that, again, age dependent. Newborn children, they go through this process in about 2 weeks. Me, I never go through this process at my age. You get in the 60s and stuff stops happening. And so it would never completely remodel or smooth at my age. So, bone 101. How do kids grow? In long bones, it's very simple. There are cartilaginous discs on the bottom of the bones. We call those the growth plates, or physis. Physis meaning to grow. Those little cartilaginous discs you think of, and I explain to parents all the time, imagine bone grows in kids like you squeeze a tube of toothpaste. It shoots out the top and it shoots out the bottom. And so the bones, the ends of the bones are growing away from the middle of the bone. And anything that happens towards the end of the bone, near where there's metabolic activity, that fixes the fastest. And that takes and remodels the fastest or smooths the fastest. Angular deformities, if you have a bend of the bone with an angle, for example, the end of the humerus bone, if it breaks and there's an angle that it healed in, and we call it a union healing bone, and if it's not perfectly lined up, we call that a malunion. Mal meaning bad union. Those malunions will smooth over time and remodel, but they do so primarily in the plane of the joint that they're adjacent to. So the end of the humerus bone, if it's a straight bend back and the elbow bends up and forward, those heal very quickly and almost completely. If there's rotation in the fracture malunion, it can't heal as well. So there become longer term problems. So when we look at patients and we look at fractures, we look to see where the fracture is, what's the chance it's going to remodel or smooth, and is it near joints, is it going to cause any long-term deformity? And we can tell that by looking at our x-rays. Now, you get all the time, you're going to hear these terms tossed around a lot. The concept of classic fractures of non-accidental trauma or child abuse. And there are a couple classic fractures, and it all has to do with the mechanism that they occur. And primarily, it talks, the most common one, and I'll show you pictures of this, is called a metaphyseal corner fracture. And, hang on a second here. This is the end of a bone. And the arrow doesn't normally come on the x-ray, but it would be very helpful if it did. This is the growth plate of the bone. This is around a knee. The knee itself is a very young child, so the knee is mostly cartilage at this particular time. And what we look for is that the end of the growth plate, the edge of it, is a combination where the little cartilaginous ring comes out and touches the end of the bone, and the periosteum or lining sleeve comes down and attaches on that point. That point is very susceptible to shaking side by side. So if you took this limb, you can imagine, and yanked and pulled side by side, the tissues attached here would pull off that fragment. Now that fragment is actually, if you look at it anatomically in a dissection, it looks like a bucket handle. It goes up and back. It goes almost all the way around the bone, even though we only see the corner of it. So we used to call these bucket handle fractures. The proper term now is they would use metaphyseal corner fracture, and now they decided to throw one more in, the classic metaphyseal lesion. It just means the same thing. So what we look for, and we'll see them on the end of the bones, something pulled on this leg. Something shook this leg. Was it done intentfully? Was there a 3-year-old sibling playing with the 2-month-old baby? Why the parents would let that happen, I don't know, but were they yanking on the leg? Something happened to cause that to occur. And by looking at the x-ray, you see there's no new bone. And so we know this is a relatively recent fracture. Talk about other fractures we're going to talk about here, and I'll show you some examples. Rib fractures. Rib fractures are very important in understanding what happened to the child. And they're important because the interesting thing is that in a number of studies, if you are 4 or more greater rib fractures, in some studies it's up to a 70% chance of risk of death if that child goes back into that abusive environment. So rib fractures are very disconcerting. And rib fractures occur from 2 types of pressure normally. Either from front to back, where you take the chest and you squeeze and you put the sternum and you push the sternum towards the spine. Because interestingly enough, the ribs attach to the spine. They come to the front, there's cartilage. And so the chest moves up and down. If you push back on the chest directly towards the spine, the place of pressure is in the back or posterior aspect, and we develop a posterior rib fracture. Posterior rib fractures mean that there was pressure in front of the chest. Lateral rib fractures and interior rib fractures tend to come from compression from side to side, and a combination can put them in different places. So by looking at the x-rays, we can determine what the type of fracture and we can get a pretty good idea of the mechanism of injury. And so and the key is, like I said, ribs 4 to 9 are the most common. Remember, there are 12 ribs. And if you have more than 4, red flags should go off in your head in terms of the issue you need to take care of. I'm going to talk a little bit about spiral fractures of the humerus and femur. We used to think that spiral rotation, I'll describe how that happens, fractures were most associated with non-accidental trauma, but it turns out it's the other way around. The transverse, the bending fractures actually are higher association with intentful non-accidental trauma. So the old thing about having a spiral fracture as sort of a precursor to a pathognomonic diagnosis isn't necessarily true. All spiral means there's a rotational moment, and I'll show you pictures of those in just a second. And then I want to talk about skull fractures. Skull fractures are hard because there are suture lines in the skull of young children. So when we look at x-rays, and I'll show you a picture of that as well in a second, it can be very complicated, whether something is a suture line or is it a fracture. And we have some new sophisticated techniques, with not only with CT scan, but also with the ability to have three-dimensional reconstruction now, which help tremendously in trying to decide what we're looking at is truly a skull fracture or not. And again, metaphyseal corner fracture was described originally by a guy named Paul Kleinman in the 1986 article where he looked at 3 cases. And he came up with this term of, in terms of the classic metaphyseal corner fracture. Interesting enough, Dr. Kleinman is a professor at Harvard. And one of the big debates we have in this business, when you look at literature, is that interestingly enough, a lot of things that we call a metaphyseal corner fracture, up to 1/3, don't go through the normal healing process that I described of long bones. And I couldn't, and you know, I'm kind of a scientist, I couldn't figure out why that would be. How can something not be physiologic? Either A, it wasn't a metaphyseal corner fracture to begin with and just something projectional, or some normal variant, or B, there has to be something unique about that fracture. So I called Dr. Kleinman actually one day. We were having that discussion. There's a very good expert here. You guys hopefully use Dr. Shaw. He's a wonderful guy, and he and I had this great discussion. And he said, well, just call Kleinman and ask him. So I called Professor Kleinman at Harvard. This was about 2 years ago. And I said, Professor, you know, I've looked through all your articles you've written, and I'm trying to figure out how 1/3 of these metaphyseal corner fractures do not cause callus to appear on subsequent x-rays. And he had a very great answer to me. He said, there is no science. Stop reading the articles. I said, I don't think I can do that. Basically, if it shows callus, and I'll show you examples of it, we know it's a classic metaphyseal lesion. We know it's metaphyseal corner fracture. If it doesn't show callus, and the x-rays look the same in the subsequent follow-up x-rays, it's very unlikely it's a classic metaphyseal lesion or a corner fracture. So I showed you this picture. This is kind of an idea, another view that these fractures will come across where the growth plate is, and you'll see separation sometimes, especially on the lateral or side views. This also gives you an idea of a knee. Most of the bones in children are still cartilage. So one of the challenges we have in orthopedic surgery is not only just looking at x-rays to decide what we're seeing, but is to you can imagine if you have to do surgery on a limb to put something back together and you can't use x-ray to help you, you're using the cartilage, it makes it very, very challenging to put back together correctly. Now here's an example, and I appreciate this, maybe a little hard to see. You see the corner way up in the very top there? Hopefully everybody can see that. Now this was a child who came in with an injury and had some swelling around the shoulder. They noticed this lesion at the very top of the humerus bone. That's the growth plate of the humerus, and they noticed that little corner lesion there. And then 2 weeks later, see the callus formation now coming streaming down the side? That's the classic that you should see. And by the way, this child also, which one of you are going to recognize this because it's one of your cases there, I don't know what you do. But there's also a similar callus we see at the end of the clavicle. That's an incredibly rare thing to have a clavicular classic metaphyseal lesion or corner fracture. This is the only one I've ever seen in about 20-some years of looking at this. And the interesting thing here is that the callus we see, just like the callus there, is occurring over time. So is this happen at one event? Was someone yanked on this arm hard one time? Probably. Could it have been two separate events, a couple days apart? Could be. And unfortunately, that's the kind of answer you get from me when you ask me out on the stand. Could it occur at the same time? Because I don't understand, in your business, it's a huge difference that they happen at two different times versus a single time. Could it happen at the same time? Absolutely. Could it happen a couple days apart in two separate episodes? Absolutely. And the good thing, I get to go home then, you guys have to argue. But, so that's a classic thing we see. And so it's that new bone that's laid down. And the reason that happens is that the periosteum, which is outside the bone, is kind of analogous to the sleeve of my shirt on my arm. And if I disrupt that sleeve, that's when the new bone forms. You get bleeding and new bone formation. So this is kind of a classic issue. So the rib fractures, as I talked about, the posterior versus lateral, squeeze versus direct trauma, very difficult to pick up rib fractures a lot of times unless it's in the healing phase. So this is an easy one to pick up. You see the rib fractures here posteriorly, 1, 2, 3, 4 of them posteriorly, very easy to see overlap. This is actually an autopsy photo. It's rare that this happens this way. Most of the time, it's much more subtle. And this is what we more commonly see. This is a front view of a child, and see the round thing kind of looks like an olive there? That olive that we see on the ribs is the healing rib fracture. And when you look at the x-ray here, what you'll see, if you notice, the olives look very similar. Did these rib fractures occur at the same time? You're going to get the good answer, probably. Okay, or very close in time. And we really can't see, or barely see maybe a fracture line, in which case these rib fractures are about 3 weeks old, maybe as long as 4 weeks. So that's the kind of window we can give you when you're trying to discuss with the parents and the other witnesses when things might have occurred. Spiral fractures. Interestingly enough, a spiral fracture occurs from a twisting movement. We call these forces moments in orthopedic surgery. So a spiral fracture occurs from a spiral or twisting moment. A transverse fracture is probably the easiest one to understand. If you take your thumb and you bend it, it snaps. A transverse fracture happens from a bending moment. To have a transverse fracture, you have to bend. To bend, you have to hold either end and have a fulcrum in the middle you bend over. A lot of times, when it comes to pediatric orthopedics and young children, the fulcrum is the end of the caregiver's hand or person's hand. If they hold the arm and they lift up, the baby's body acts as the other side of the counterweight and bend across the edge of the hand. That hand becomes the fulcrum. So a lot of times when we see midshaft fractures in the humerus, a lot of times that's someone, if a 2 or 3 month old baby decides to pick them up without grabbing them, grabs them by the arm and just lifts. And then it just snaps. How much energy, I get asked that question a lot, how much energy to cause a fracture like that? Well, remember, we talk about force is mass times acceleration. You remember that from your own college physics days. And we talk about a Newton of force. A Newton of force is the amount of force it would cause to accelerate 1 kilogram 1 meter per second. That's Greek to everybody here. So the number, when we ran it in the lab, in our models and simulations, to break a femur is anywhere between 60 and 70 newtons of force. To break a humerus is between 40 and 60 newtons of force. What does that mean? We'll give you an idea. It takes about 40 newtons of force to crush a soda can. That's kind of or to snap a pencil. And if you ever take a pencil and if you do the test yourself, if you try to slowly break it, it takes a lot more force. If you jerk it, it breaks quickly, because remember, force is mass times acceleration. So I get asked that a lot. How much force is required for these fractures to occur? And their answer is, it all depends. And how much quickly that force was applied, if you will. What was the acceleration moment? So we can't give you a great answer for that. So that's why you'll find us hedging all the time when we testify. So I'm going to show you a rotation fracture here in a second. You saw an example of a transverse fracture. If I have one here. Here's a transverse fracture going straight across. It's a bending moment. And here is an example of this. A spiral fracture comes around like a barber pole. I'm going to give you a better example of that in a second. This is more of a combination of the two called oblique fracture. When we can't say it's spiral and we can't say it's transverse, we call it oblique, and we feel better. I'll get to my other one here in just a second. So, skull fractures. I want to talk a little bit about skull fracture. Heaviest part of the baby. If you drop a baby, the baby's going to go to ground, the skull's going to lead the way. The parietal bone, the skull is made up of different bones. Occipital bone in the back, 2 parietal bones, and a frontal bone to the front. The parietal bone is the most common fracture because kids tend to twist a little bit as they fall. If they go straight back, like off a chair, they may hit the occipital bone in the back. Or if they take a header to the front, they'll get the frontal bone to the front. Unfortunately, skulls in kids are plate bones. They don't heal like a long bone with the same amount of callus or callus formation. They heal with what's called endosteal healing, where the healing comes across the fracture and grows and interdigitates. So we can't date them, skull fractures, like we can date long bone fractures. And about the only thing we can tell is the associated soft tissue injury, which we call the hematoma, the bump on the side of the head. That's the most common reason a mom will bring a baby to see the pediatrician, is they notice a soft spot on the side of the head. And that's a collection of blood. And that blood collects between the skull and the fascia, called the glial fascia. Back in the days when they used to scalp people, that's what they did. They would cut across the front and they would pull the glial fascia right off the skull. That's what gave you a scalp. I'm sure when you're eating lunch you want to know about that. Typically, this bleeding occurs within 24 to 48 hours. So, if we have a child come in with swelling on the side of the head, and the CT scan shows as well the hematoma, and I'll show you a picture of that, we know this fracture had to occur probably within a day or two, and no more than 3 to 5 days. After 5 days, the hematoma starts to go away. The other thing you look for, I look for, especially in the emergency room, is evidence of tool mark. I can't tell you how many times I'll read a report from some of our specialists in Children's Hospital, and they'll talk about the child being hit on the head as possibly causing this fracture. Well, to me, the problem with that, if you get hit on the side of on the head, because if there's no tool mark, if nothing has indented the skin or caused a cut in the skin, whatever hit him had to be flat. And the biggest flat thing I know is the floor. So for me, the most common thing is a kid that hits the floor. They've done lots of studies to show that how far does a child have to fall in order to get the acceleration to cause a fracture moment. I can tell you the data is all over the place. The only good study was done actually in England in adults, and they showed that an adult male falling at a standing height is enough force to cause a skull fracture. Now, I'm not sure how they got volunteers to do that, but they essentially did. So, for me, it's more a situation of there has to be the action of the fall. Remember, when you fall, gravity takes on at 28 feet per second. So, can a fall of 6 inches cause a skull fracture? Very unlikely. Can a fall of up to 18 inches or a low mattress on the floor cause a skull fracture? Unlikely. Can a roll out of bed at 2 feet, 2.5 feet, 30 inches is a common counter cause a fracture? Most assuredly. It depends also what kind of surface they fall onto. Is it a rug that's laid on top of a concrete floor? Is it hardwood floor? Is it tile? All these factors you take into consideration. And a lot of times you're going to get, unfortunately, the same answer from your experts. Probably, I think so, compatible with, consistent. So, this is the common problem we see when we get an x-ray. And just for you guys, does anybody see the skull fracture here? Answer is, all you see, hopefully, besides these open mouth, that's the open mouth screaming sign of a kid who had his x-ray taken, by the way. What we see here, these are the suture lines. And interestingly enough, what the radiologist looks for is the too many lines sign. If there are too many lines, suture lines, there's probably a fracture. And so the too many lines sign is the most common determinant when we see a skull x-ray. So this one's easy. This is a CT scan. It's not hard to see the fracture here. You see the skull, you see the huge hematoma. This is an autopsy photo. This one's a little more difficult. This is more the classic one that we see. This is a bone window, and I'll show you when we do a CT scan, they can do a window. They call it a setting of the machine where they can see bone really well. And they can do a window setting machine to see the soft tissues really well, where they're looking for subdural hematomas and blood products. So in this particular case, what we see is we see soft tissue swelling on the side of the head, but we really do not see a disruption of the bone window of the cortex. Now, that's fairly common, and yet there's a fracture here. How does a CT scan miss the fracture? Because CT scan takes slices, and those slices are between 4 and 6 millimeters. So if you have a fracture that's running in a plane that the slice misses, you're going to miss the fracture on CT. So the next step is to do a little thing, which is this is a 3D reconstruction. All of the new CT scanners have this technology. It's phenomenal technology.